11. So two kinds of anemia I've already talked about. That was the iron deficiency anemia, and second one was the vitamin B9 and B12 deficiency anemia. Third anemia which we are going to talk about now, that is the sickle cell anemia. So in the sickle cell anemia, what things you should remember over here. So look, if this is the RBC, first of all, what is the shape of the RBC? Normal shape of the RBC is biconcave. Okay, it's a biconcave shape. Now look, in the sickle cell anemia, what happens is, in the sickle cell anemia, your RBC will look like this, which is actually sickle shape like. Okay, one more thing I would like to add up over here. In the normal individual, in the adults, A for adults, HbA1 and HbA2 can be appreciated. In the adults, HbA1 and HbA2 can be appreciated. So A for what? Adults. In the fetus, HbF can be appreciated, F for fetus. And in the sickle cell anemia, there will be the formation of HbS, as for sickle cell. Okay, that should be remembered. Next thing we should be remembered over here, that there will be the substitution of the amino acids. Which amino acids I'm talking about? I'm talking about two amino acids, that is glutamic acid and valine. From the 10th standard textbooks, we are reading the sickle cell anemia, that substitution of valine with glutamic acid, valine with glutamic acid. But remember, what should be remembered over here? The position. The position is actually 6th. At 6th position, there is substitution of valine with glutamic acid. Okay? Substitution of valine with glutamic acid. Okay? So that should be remembered in the sickle cell anemia. And unfortunately, these kind of childrens, they are actually not able to survive because they are having which hemoglobin? HbS. HbA is compatible for us. For the fetus, HbF is compatible. So HbF gradually convert into HbA as the fetus is growing older. Okay, but HbS is actually incompatible with life. So that's why this kind of patient, because look how they will be carrying the hemoglobin. They will not be able to carry hemoglobin actually. Because for carrying the hemoglobin, you need this biconcave shape. Okay, understood about this one? That is the sickle cell anemia. Okay, next question. Inflammation is characterized by increasing penetration of vessels of microcirculation stream, increasing of their fluid dynamic blood pressure, increasing of the osmotic concentration, disparity protein structures. So they are actually talking about the edema in this case. Okay, so if you will be looking at this question, there was an inflammation, and then penetration increases of the vessel side in the microcirculation stream, and there was disparity of protein structure and the fluid dynamic blood pressure. What is actually happening? Look over here. Look, let's say this is the blood circulation over here going on. This is a blood vessel, and here you can appreciate the tissues. Okay, these are the tissues on both the sides of the blood circulation, right? Okay, now what will be happening? So two kinds of forces I'm going to talk about over here. These two kinds of forces will be hydrodynamic or hydrostatic. Okay, please pay your attention, very important topic, hydrostatic pressure, and then second one is the oncotic pressure or colloid-oncotic pressure. We are also calling that as colloid-osmotic pressure. Okay, colloid-osmotic pressure. So these two forces I am going to talk about. Now look, let's say this is the colloid-osmotic pressure, and let's say this is the hydrostatic pressure. Okay, what's happening? Usually there is a balance between colloid-osmotic pressure, that is the oncotic pressure, and hydrostatic pressure. Now when the edema happens, if there is an imbalance between these two forces, edema will be happening. What is edema? Let me tell you, edema will be that if the plasma which is flowing in the blood circulation, if the fluid will be leaking into the interstitium of these tissues, that will lead to edema. Okay, so increased amount of fluid in the interstitial, that is actually the edema. Now what actually happens is that you are having the plasma protein inside your blood circulation, and which plasma protein I'm talking about? I'm talking about over here is, that is mainly albumin. Albumin is kind of a protein, right? Albumin is having the tendency to hold the water inside the blood circulation. If somehow you will be losing the albumin, for example in the form of urine, proteinuria is there, you're losing the albumin, will you be able to hold proper amount of fluid in the blood circulation? You will not be able to do so. So it might lead to what? It might lead to shifting of the blood from the blood circulation into the tissues, right? Is it normal? It's not normal actually. Okay, Fine. Now what will be happening? Let's say this was the oncotic pressure, this was the hydrostatic pressure. Hydrostatic or hydrodynamic force, this one actually favors the edema. It actually favors the edema. Colloid-osmotic pressure, oncotic pressure, it opposes the edema. That thing should be clear first of all. Okay. Now, if anyhow hydrostatic force or colloid-osmotic pressure, if it is decreasing, comparatively hydrostatic pressure will be increasing. Will it lead to edema? Yes, it will lead to edema. Okay. That's what happens in this case. Whenever the albumin is actually decreasing, colloid-osmotic pressure or oncotic pressure, it actually drops. If it drops, comparatively hydrostatic pressure increases, and that's how it leads to edema. So I can say if the person will be having edema, oncotic pressure should be and hydrostatic pressure or hydrodynamic pressure should be. If both forces are involved, then I can say mixed kind of edema. And that's what the question saying. Okay, that's what the question saying, because look at the question over here now. Now it will make more sense. So they are saying that fluid dynamic blood pressure is increasing and osmotic concentration and disparity of protein structure is happening. Okay, which means disruption of the oncotic pressure. Okay, and that's how it leads to edema. So this is actually which kind of edema? This is actually mixed edema, because both forces are involving over here. Clear? Shall we move on to the next one? 13th. Okay, so that was about the edema. Okay. So in the next question they are saying disorders of airways passage in the small and middle bronchi was revealed in the patient. What disorder acid-base equilibrium can be detected in the patient? So disorder of airways passage, if I'm talking about disorder of airways passage, we are very well familiar with the exchange of the gases. We are inhaling the oxygen, we are exhaling the carbon dioxide, right? That is very, very clear. Now if somehow there is disruption in the exchange of these gases, it might lead to acid-base imbalance. Now what you need to remember for the acid-base imbalance, what things you should remember? First of all, you should be aware of blood pH. What is the normal physiological blood pH? That is actually the 7.35 to 7.45. This actually should be clear in your mind. Then you should be clearing in your mind that CO2 concentration, which is actually 35 to 45 millimeter of mercury. Okay, that should be clear in your mind. And next thing which should be clear, which is the bicarb concentration, which is the hydrogen carbon and SCO3 concentration, which you should be taking 22 to 26 milliequivalent per liter. These three things should be cleared, okay, in your mind as far as acid-base imbalance concept is concerned. Okay, so these three things please keep in your mind. Fine. Now one thing is very, very clear. If 7.35 to 7.45, this is the blood pH normal range. If it will be dropping below than 7.35, can I say that as acidosis? Can I say that as acidosis? If it is more than 7.45, can I say that as alkalosis? Yes, I can say that. Okay, so 7.35 to 7.45, that is the range. Now one more thing, if I am talking about lungs, I can talk about respiratory system. I can talk about respiratory system. If I am talking about kidneys, I am going to talk about the metabolic system. Metabolic system. Okay, so two organs are involved as far as acid-base imbalance is concerned. That is the lungs and kidneys. Okay, whenever the lungs will be in the problem, kidneys will compensate for the lung, and whenever the kidneys are in problem, lungs will compensate for the kidneys. Three entities should be clear in your mind, the normal values of them, that is blood pH, CO2 and HCO3. In this particular question, they are saying about the disorders of airways. If they are talking about disorder of airways, which organ they are talking about? Lungs. They are talking about lungs. So one thing is very, very clear, that answer will be respiratory system. Answer will be towards respiratory system. Now if you talk about some kind of disorder of airways, which means the person is not able to actually, what the person will be doing. The person will not be able to exhale proper amount of carbon dioxide from the lungs. If the person will not be able to exhale proper amount of carbon dioxide from the lungs, CO2 concentration inside the lungs will be increased. So CO2 concentration inside the lungs, if it is increasing, I call this situation as hyper means more, capnia means carbon dioxide. I can call this situation as hypercapnia. Okay, so CO2 concentration is increasing. CO2 actually decides the acid content inside your blood circulation, and HCO3 actually decides the base, right? If CO2 concentration is increasing, I can say that as acidosis or alkalosis? Acidosis. They were talking about the disorders of airways. They were talking about lungs or kidneys? Lungs. And if they're talking about lungs, they're talking about respiratory system. Can I say respiratory acidosis? I can say that, right? Respiratory acidosis. Okay. Sometimes they ask you about the pH. They will be giving that the pH of the person is given 7.33. 7.33. What is the case over here now? Acidosis. And they will be giving you the random value. For example, CO2, it is given, right, for an example, and SCO3 they are giving over there. Okay, CO2, let's say they are giving you with the value of, let's say, 50.
More than.
Okay, and SCO3 gave 25. What is the answer over here? Acidosis. But which acidosis? Respiratory, because look at the content of CO2 and look at the content of SCO3, 25. It is actually falling in the range, normal range. So this is the case of respiratory acidosis. Okay, fine. This question is clear? Okay. Okay, some more examples I would like to add over here in the acidosis alkalosis concept. If the person is having the COPDs, that is chronic obstructive pulmonary disease, you should be remembering about 3 examples of the COPDs. First one is the bronchial asthma, second one is the chronic bronchitis, and third one is the emphysema. These 3 examples are for COPD, that is chronic obstructive pulmonary disease. They are actually obstructive problem. Obstructive. So hypercapnia will be there or not? Hypercapnia will be there. Respiratory acidosis, can I say?
Yes.
Yes. So respiratory acidosis is having the example of COPD. Some asthma, yeah, asthma is also the example of COPD. So that is the respiratory acidosis problem. Then some kind of chest trauma. Chest trauma might lead to rib fracture. It might lead to the puncture of the lungs. It is actually causing the more and more accumulation of CO2 inside the lungs. Again, it will lead to what? Hypercapnia, respiratory acidosis. Vomiting can be the example of vomiting, because in the vomiting, alkalosis actually, in the vomiting, am I talking about lungs? I'm not talking about. Forget about respiratory system. Talk about the metabolic. Vomiting means I'm losing the gastric content. In the stomach, we are having acidic environment or alkaline environment? Acid environment. You are losing up your acid. If you are losing your acid, let's say this is acid, this is base. If you are losing up your acid, what is high? Base. So you will be having alkalosis or acidosis? Alkalosis. Which kind of alkalosis? Metabolic, because you are not talking about lungs over here, right? So metabolic alkalosis, what example you can talk about? Vomiting. Let's take different example. Let's talk about the diarrhea. In the diarrhea, am I talking about lungs? I'm not talking about the lungs actually. Okay. Metabolic or respiratory? Metabolic. Acidosis, alkalosis. This will be acidosis. Why is it so? Because in the diarrhea, you are losing the base. If you are losing the base, comparatively acid content will be higher inside your blood circulation. It will be case of metabolic acidosis. Kidneys are having the capability to either excrete out the base, either excrete out the carbonate, bicarbonate, or either to retain the bicarb. Okay, it actually depends on the situation that person is having acidosis or alkalosis. If the person will be having acidosis, which means more acid content, it will retain the base or it will excrete out the base. Kidney will, if it will excrete out the base, this will be the how the balance will be attained. Look, acid content is already there, acidosis. This is the base. This is the situation. It should excrete out, kidney should excrete out, kidney should retain. Kidney should retain. On the other side, let's say if I am having if any kind of patient is having the alkalosis, metabolic alkalosis, let's say metabolic alkalosis means this kind of situation is there. Now lungs has to compensate for me. So they should increase the acid content or they should decrease the acid content for getting the equilibrium. Increase the acid content. If they want to increase the acid content, how they can increase? By accumulating more CO2 inside the lung. How I can accumulate more CO2 inside the lung? By breathing in the paper bag. If you're breathing in the paper bag, you are excreting out the carbon dioxide. Again, you are taking your carbon dioxide inside. That is actually what? You are increasing the amount of carbon dioxide inside the lung. Okay, that's how it makes sense. If you want to excrete out more and more carbon dioxide, you will need to hyperventilate, because you are inhaling the oxygen, but at the same time you are exhaling more amount of carbon dioxide as well. Okay, that will lead to hypocapnia. So that's how you compensate. Okay, so please remember about these examples. Vomiting was example of metabolic alkalosis. Diarrhea was example of metabolic acidosis. COPD, chest trauma, they are example of respiratory acidosis. Hyperventilation is an example of alkalosis, because you are removing out more and more amount of CO2. That's respiratory alkalosis. You don't even need to remember them. Okay, that actually makes sense. You can think about them. Yes, that you will be losing the acid, which means yes, there will be alkalosis. Okay, so that's how you can analyze these examples. Okay, so that was about the question number 13. Question number 14. 62-year-old patient was admitted to the neurological department due to cerebral hemorrhage. Condition is grave over here, and there is observed progression of the deepness and frequency of breath that turns into reduction to apnea and cycle repeats. What respiration type has developed in this patient? Okay, so if you will be talk about this question, they are actually saying that progression of deepness and frequency of breath, and then it is reduction to apnea. So look over here. If I will be talking about this diagram, so okay, let's say this is the baseline. This is the baseline. Over this baseline there will be the inspiration. Under this baseline there will be the expiration. So look, this is actually, if the graph is going like this, which means no breathing. So this is the apnea stage. You start to take inspiration, expiration, inspiration, expiration, inspiration, expiration. This is increasing, and then slowly it is decreasing, and then again apnea, and then this cycle repeats. Okay, this cycle repeats, and then again apnea. What is actually happening? Look at the graph. Right? So what is happening? Increase in the depth of frequency. Okay, so this kind of thing, like you start to inhale air, exhale air, that more forcefully you inhale air, more forcefully you exhale, more forcefully you inhale, more forcefully you exhale, then slowly you inhale, slowly exhale, slowly inhalation, slowly exhalation, and then apnea. Okay, this kind of cycle actually repeats at regular interval of time. And we are talking about which respiration? This is the Chinese Stokes respiration. This is what? Chinese Stokes respiration. Exactly that scenario which is given in the question over here. Okay, so this scenario is given in the question, that this patient condition was grave, and this kind of patient who are having the head trauma, these kind of patients are having with this kind of respiration usually. Okay, and in our question they are already talking about the cerebral hemorrhage. Cerebral hemorrhage means brain cerebral hemorrhage, right? So observe progression of deepness and frequency of breath. So this is the frequency of the deepness and progression of the breath. Okay, so that is the example of Chinese Stokes respiration. This kind of graph will be seen over here. Okay, one more example I would like to add over here, which is given in the option B, Cosmol respiration. In the Cosmol respiration, it is actually seen in the diabetic patient. So diabetic ketoacidosis patient, they will be having the Cosmol respiration, in which they will be having the labored breathing. So look, I have talked about this kind of thing, how our respiration rate will be looking like. So how our respiration will be looking like? Look, this is the inspiration, expiration, inspiration, expiration, inspiration, expiration. Okay, so this kind of graph will be looking. This is actually normal. That is actually normal. And if I will be talking about the Cosmol respiration, this was the Chinese Stokes, this was normal. And if this is the baseline again, and how there will be the Cosmol respiration, there will be labored breathing. Labored breathing means, look at the graph. That will be continuous, but in this manner, in this fashion. Okay, and that is example of what? That is example of Kussmaul breathing. Kussmaul breathing can be appreciated in which patient? It can be appreciated in diabetic patient. It means diabetic ketoacidotic patient. Diabetic ketoacidosis patient is actually having the acetone smell from the mouth. Acetone smell from the mouth. Okay, if I'm talking about the diabetes over here, please remember 3 complications of diabetes, because most frequently they ask you the complications of the diabetes. Please remember these complications over here as well. Okay, diabetic complications. So first complication you should remember over here is that is diabetic neuropathy. Diabetic neuropathy. Second, which is diabetic retinopathy. Diabetic retinopathy. And third one, but not the least, that is actually diabetic nephropathy. Diabetic nephropathy. Okay, diabetic nephropathy. Nephropathy is very, very clear. It means there is a problem in the kidneys. Retina, there is a problem in the eyes. Okay, so whenever the patient comes to you and you diagnose it diabetes, you will refer this patient to ophthalmologist, you will refer to patient to neurologist, and you will refer this patient to nephrologist as well, because there are the complication. Diabetic neuropathy is very unusual. This kind of patient will neuropathy, which means they are having the nerves damage. Now what will be happening? They will not be aware that what is happening to them usually. That's why these persons are having more chances of those patients who are having the diabetic neuropathy. First of all, they are having the problem with the diabetic foot. Diabetic foot. Have you heard about that?
Yes.
Gangrene may happen in those cases. Okay. Then you should also aware of angiopathy. Microangiopathy is seen in microangiopathy is seen in, again, which one? This one, diabetes. Okay, so diabetic foot. So look at the funny scenario, you can say. I should not call that funny actually. Let's say the person they are actually sitting in the front of the heater, and this is a cold season, let's say, and the person was actually taking the hot sensation from the heater, and in that manner they are actually taking the heat onto the foot region. Okay, now this is that kind of scenario where this person will not be able to feel the heat actually, how much amount of heat. If we are actually doing in that manner, we will be feeling the heat and will be removing our feet from that. Okay, but in that person, because they are having neuropathy, will they be able to feel the heat? They will not be able to, and they will literally burn their feet in front of the heaters, and they will not be able to know that. Okay, because they are not feeling the pain for that region. And most of the patient are coming to the doctor with the condition of these kind of things, that they will be saying that I was sitting in the front of fire or some bonfire or something, heater kind of thing, and they actually literally burn their surface of the sole of the feet. Okay, so that is actually the main problem in the diabetic patients. Okay, so moving further, now we have talked about how many questions? 14. Okay, 15th question. In a 45-year-old patient on ECG, it was revealed that sinus rhythm number of auricular complexes exceeding the number of ventricular complexes over here, progressing extension of PQ interval. So we are very well aware that if you will be seeing the graph of ECG, electrocardiograph, we are very well aware about the waves, that we are having the P wave, we are having P wave, QRS complex, and then T wave, and sometimes U wave is also appearing. U wave is due to papillary muscles. So this is the P wave, this is Q wave, this is R wave, this is S wave, and this is T wave. We are very well familiar that P wave is for atrial depolarization, and QRS complex is for ventricular depolarization, and T wave is for ventricular repolarization. Okay, this is very, very clear in our mind. Okay, if I am saying P wave is for atrial depolarization, which means for that particular period of time, the waves will be in the atrium, then they will be entering to the AV node, and at that particular time, for that particular time, you will be having which wave? Q wave, and then ventricles will undergo depolarization. Then you are having which one? QRS complex. Okay, QRS complex, and then finally ventricles. If the ventricles are undergoing depolarization, obviously ventricle has to undergo repolarization as well. Okay, the relaxation as well. That is actually happening. But now let's say this was the heart. I rub that heart, right? Okay, there was a heart. From the atrium, there will be the migration of the electrical impulses from the atrium into the ventricle region. If it is happening, what may happen further? If physiologically, if my AV node is working well, AV node is only and the only door between atrium and the ventricle. Okay, if AV node is having some kind of blockage, will the electrical impulses be able to go into the ventricles? They will not be able to do so. So in the AV blocks, we are having the same problem, that the atria are actually undergoing depolarization, but the waves are not able to go from atria into the ventricles. Okay, so that is the main problem in the AV blocks. Band ho gaya kya? Okay, so what is actually happening in the AV blocks? In the AV blocks, you are having the problem in the atrium region. So AV node will not be able to pass the electric impulses from the atrium into the ventricle. Now AV blocks is actually having the types: AV block type 1, AV block type 2, AV block type 3. Okay, in the first AV block, still some kind of impulses can travel from atrium into the ventricle. Okay, so let's say this is the heart over here, and in between this one you are having this is what? Let's say this is what? AV node. Okay, now with the help of this one, impulses has to come. If there is some kind of blockage over here, will the impulses be able to come over here? They will not be able to come into the ventricles. So in the AV block type 1, still the impulses, some of the impulses can travel from atria into the ventricles. In the AV block type 2, in the AV block type 2, some impulses can come into the ventricles, some impulses can be remaining in the atria only. But in the AV block type 3, no impulses are coming into the ventricles. Okay, if in the atrium for a longer period of time electrical impulses will be remaining over there, P wave, will it be longer? It will be longer, right? Because it is remaining in the atrium for a longer period of time. So for that particular case, you will be having the longer P wave. And then if the impulses are coming in the ventricle for a very short period of time, QRS complex will be lengthening or QRS complex will be shortening? It will be shortened. So QRS complex will be seen as shortened, and then you will be having T wave. Okay, so P wave will be exceeding the QRS complex. P wave will be exceeding the QRS complex in the AV blocks, and that's what is given in the question. Okay, that's what is given in the question. Further, AV block type 2 is also having further type, that is actually Mobis type 1 and Mobis type 2. Okay, Mobis type 1 and Mobis type 2. Okay, so that should also be remembered over here. So always remember, P wave will be exceeding the QRS complexes. P wave will be exceeding the QRS complexes because for a longer period of time impulses will be remaining into the atrium region only. Okay, understood?